If you are worried you have Lyme disease, or just like the outdoors, and want the peace of mind of knowing whether you have Lyme disease or not, there is a new Lyme screening test based on decades of research by Dr. Richard Marconi, a professor at VCU Medical Center. For more information, visit glymedx.com. That's glymedx.com, or email at info@glymedx.com.
Infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
My first guest today is going to be Stephen LaRosa, MD, and we're going to discuss several topics in general infectious diseases. Dr. LaRosa is an infectious disease physician. He's based out of Beverly, Massachusetts. Dr. LaRosa, welcome to the show, sir.
Hi, good evening. Thanks for having me.
Glad to have you. Now, I thoroughly enjoyed reading your blog. It's entitled My Thoughts on the Future of Infectious Disease in Medicine. And if you're interested in it, you can check it out online at drlarosa.blogspot.com. And there's a few articles I really wanted to look at with a little more detail here on the show today. And the post that intrigued me the most was what you called my favorite infectious disease teaching points, or you call it your pearls. And you list 21 pearls. And they're concerning treatments, they're concerning diagnostics, and the information that you're teaching medical students. And I'd like to have you elaborate on some of them. So the first one I'd like to have you talk about is, you write, for patients with pneumonia, order a MRSA screen on the nares and throat. If these are both negative, you do not have a sputum culture with MRSA, so you can stop the vancomycin. Can you talk more about that?
Yeah, sure. I mean, by and large, vancomycin, which is used against MRSA infections, is overused, and it's usually included as an empiric component of treatment for hospital-acquired pneumonia and healthcare-associated pneumonia. Yet, there's good data from a few studies now that if you don't have a sputum that grows MRSA, and oftentimes you won't even have a sputum culture in cases of pneumonia, that if somebody does not have MRSA from a culture of their nose or throat, you're actually able to safely stop the vancomycin and not include it as part of the empiric treatment of pneumonia. So it's really become a key component of stewardship to try to save vancomycin for when you really need it and not give it excessively.
Yeah, and that's really something that you focus on your blog, is antibiotic stewardship. And another pearl that you mentioned in the blog is, I do not use vancomycin for MRSA infections where the vancomycin MIC is 2 or greater. Can you first explain to the audience what an MIC is, and then explain your thinking behind this? Sure.
So an MIC, or mean inhibitory concentration, is the amount of an antibiotic that you need to kill a given bacteria. And it's an in vitro test. It's done in the lab. It's done on a plate or in a test tube. And so what it is, it's a concentration. And for vancomycin, what's critical in killing the bacteria is both the concentration of the vancomycin as well as the amount of time that the concentration is above the MIC, the amount to kill the organism. And for vancomycin, the key parameter is having an area under the curve concentration over the MIC. So basically go back to your division days, AUC over MIC greater than 400. That's what your target goal is. Well, as that MIC rises, and that's the denominator again, as it goes from 1 to 2, the concentration and the dose of vancomycin that you need increases dramatically. And when you get to an MIC of 2 or greater, you often will need greater than 3 or 4 grams of vancomycin a day to achieve that. And sometimes it takes, in a young, healthy person, 6 grams, 7 grams. And we know that once you get over 3 grams a day, the risk of kidney injury, nephrotoxicity, goes up dramatically. So, one, it's hard to hit the target of an AUC to MIC of more than 400 when the MIC is 2 with vancomycin, and it's really hard to do that without incurring some nephrotoxicity. So in those settings where the lab report comes back that you have an organism with an MIC of 2 or greater, I go to an alternative agent such as daptomycin or ceftaroline or an alternative agent. So it's just it's the key parameter. People often will, and even in guidelines, will tell you to check vancomycin troughs, but those aren't as reliable as calculating an AUC to MIC.
Okay, very good. Now, vancomycin, you write, is inferior to beta-lactam drugs for the treatment of serious methicillin-susceptible Staph aureus infections. First, what is a beta-lactam drug, and can you elaborate on that, Pearl?
Sure. So the beta-lactam is part of the chemical construct, the structure of an antibiotic, and the classes. Typical beta-lactam drugs are the penicillins and the cephalosporins. And for an organism that's a so-called methicillin-sensitive Staph aureus or oxacillin-sensitive Staph aureus, there's now a number of studies in critical illness that using a beta-lactam such as nafcillin or oxacillin or cefazolin, the outcomes are much better than if you use vancomycin. And this will probably get into something that we'll talk about is that, people are inappropriately ascribed a penicillin allergy, and they're given vancomycin, and that's not for an MSSA infection, and that's not without some potential complications. So the point being is if the infection is MSSA, you're always based on data better off giving a beta-lactam drug than vancomycin.
Right, and you say there's potential complications. You've already mentioned the toxicity of vancomycin. What other complications are we talking about?
From the vancomycin itself?
Yeah.
So nephrotoxicity, bone marrow suppression from vancomycin, and just the outcomes being poorer with a methicillin-sensitive infection based on numerous well-done studies. Mm-hmm. So and it's really in the patient's best interest for them to get a beta-lactam agent in this setting.
And cost is an issue too, isn't it? I mean, vancomycin is not cheap.
It's a lot cheaper now, actually, that it's really off patent.
Okay.
Usually it's not and in fact, to get back to the previous point about the AUC to MIC, you often have to make a serious claim of when you want to use an alternative drug to vancomycin because vancomycin is a lot cheaper than a lot of the alternatives. But I think there's good basis that when the MIC is high that you shouldn't use it. I
can remember years ago I read an article and it was saying that vancomycin is more expensive than gold per ounce. I don't know how true that was, but
yeah. Well, unfortunately, it's relatively cheap compared to some of the newer anti-staphylococcal agents that are out there.
Another pearl you write is if Staph aureus grows in a blood culture within 14 hours of the time it's collected, then an endovascular infection is likely. What do you mean by endovascular infection? And elaborate on that point.
Sure. So when I refer to an endovascular infection, I refer to infection that is within a blood vessel, a vein or artery, or another cardiovascular structure such as a heart valve. So everyone understands. So when blood cultures are collected, they're usually collected into 2 tubes, an aerobic and anaerobic bottle. But the technique, they're put into an automatic reader, which reads the bottles continuously to detect bacterial growth. within the blood culture system. So you actually get an exact time where the blood culture has been collected, but you get an exact time of when the machine that reads the blood cultures triggers that it's a positive result. And the time that it takes between it's collected and it's positive is called the time to positivity. And that's an exact number that you can get from the lab. And it's a very good surrogate marker for how many organisms are actually present in the blood. So it tells you really about burden of the bacteremia.
Sure.
So it stands to when you have a large number of organisms in the blood culture will grow a lot faster. The time to positivity from the lab will be short. And there's good data that when it's less than 14 hours in the setting of Staph aureus, that what it should tell the clinician is that there is an infection either within a blood vessel or on a heart valve. So it should trigger either ultrasounds in the case of blood vessels or cardiac echoes to be looking for endocarditis.
Oh, very interesting. All right, let's get a word from our sponsor. For many years, we have been waiting for a Lyme disease test that actually works. After decades of research by Dr. Richard Marconi, a professor at the Medical Center at Virginia Commonwealth University, a breakthrough test has been developed. The GLD test, recently launched by Global Lyme Diagnostics, is based on Dr. Marconi's science. For more information, visit glymedx.com. That's glymedx.com, or email them at info@glymedx.com. I'm talking to infectious disease physician, Dr. Stephen LaRosa, and we're just going over a variety of different topics in infectious diseases, and the topics that I'm going over is out of his blog. It's called My Thoughts on the Future of Infectious Disease in Medicine, and that can be found at Dr. LaRosa, drlarosa.blogspot.com, and I'll put the link up on my website if people want to check that out. Dr. LaRosa, you write that for patients with severe babesiosis, I give triple therapy with clindamycin, azithromycin, atovaquone, as clindamycin has the most rapid killing based on time kill curves. Can you lay that out for the layperson?
Sure. So for those who aren't aware, so babesiosis is an infection caused by an organism called Babesia microti. And it's a tick-borne illness. It's, in fact, carried by the same Ixodes tick that carries Lyme disease in the same areas. And it essentially causes what I like to call it or describe it to people as American malaria. The way it causes disease is it actually parasitizes, gets into the red blood cells, and causes them to lyse or hemolyze. And so you get this severe hemolytic anemia where you drop your blood counts, and that can cause downstream effects, including respiratory failure, renal kidney failure, and as well as liver impairment. So it's a severe disease, and it can be really especially severe if you're elderly or you're immunocompromised, and particularly if you don't have a spleen, either due to having had it surgically removed for malignancy in the past, or having had a trauma and having had a spleen. It can be a life-threatening infection. In fact, there was just an unfortunate case published today about a patient in Connecticut that died. So it's not a trivial infection. Lyme disease gets a lot more publicity, but I've taken care of in my area. I'm practicing outside the Cape Ann area in Massachusetts, where we're in an endemic area, and some of the sickest people I see over the summer with babesiosis. So it's very important when treating this infection to one, identify it, and then to hit hard with agents effective against the organism. And it's usually you need more than one agent. And you mentioned atovaquone. and azithromycin, which is the standard regimen. But if you look at studies that have been done, and some of them are older studies, the most rapid killing of the organism, in fact, occurs with an agent, clindamycin. And so typically in one of these severe hospitalized patients, what I tend to do is give clindamycin intravenously in addition to atovaquone and azithromycin, and then I'll follow the amount of parasites that are in the blood cells as well as parameters of how quickly their red blood cells are being destroyed. And once they improve, I'll back off and remove the clindamycin. But I think it's clindamycin is an essential part of the treatment for people with severe disease.
Getting away from your blog for a moment, but sticking with the babesiosis, in your part of the country, are you seeing any significant amounts of transfusion-transmitted babesiosis?
It's a great question. So, a lot of people, particularly young people, will be asymptomatically infected. So it is not uncommon for somebody who believes themselves to be in good health to donate blood. So it certainly is an organism that gets into the blood supply. And in fact, when I practiced in Providence, Rhode Island, we saw a number of cases of transfusion-associated babesiosis, some quite severe. And actually, fortunately, through the blood bank, we lobbied, and now, at least in Rhode Island, all the blood that is screened for babesiosis. I'm not aware that that's being done in Massachusetts, but yeah, so it certainly is a concern to somebody who's receiving a blood transfusion in an endemic area.
Well, sticking with tick-borne diseases, you write in the blog, a patient is unlikely to have human granulocytic anaplasmosis with normal transaminases. Okay, that's a whole bunch of big words here. What's the disease we're talking about, and what's the laboratory test that you're talking about?
Right. So human granulocytic anaplasmosis, or HGA, used to be all called, used to fall under the name ehrlichiosis, but it turns out there's more than one disease, and not to get too far into it, but ehrlichiosis tends to occur in the south central part of the U.S., where human granulocytic anaplasmosis occurs in the northeast. And it's caused by an organism called Anaplasma phagocytophilum. And it parasitizes, it's a bacteria, but it parasitizes typically the neutrophils. You can actually sometimes see it on a stain. You can see it in the neutrophils on a stain. Not often, but sometimes it's there. But it is a systemic illness. It too is caused by the same tick that causes Lyme disease and babesiosis. So you in fact can see one of these three infections. You can see 2 out of 3. You can see all 3 in the same person, and they can occur in different combinations. And so again, Lyme disease gets the press, but some of the sickest people, again, I've seen, they've also have human granulocytic anaplasmosis. And it's a systemic illness. These people get quite ill with a severe flu-like illness. It often is presents, at least to infectious disease physicians, as they're called upon for fever of unknown origin, because there's really no distinct the symptoms are somewhat protean. They can be all over the place, but these people are profoundly ill with fever. They're often coughing because there's pulmonary involvement. But the key lab clues are they typically have a low white blood cell count, or what's called leukopenia. They'll have a low platelet count, the thrombocytopenia. They'll have some abnormal white cells, monocytes, and atypical lymphocytes. And they also get involvement of their liver, and it's usually their transaminases, so their liver enzymes, their AST and ALT. And again, it looks like a mononucleosis illness, but it's virtually unheard of to see somebody with anaplasmosis who doesn't have a blip in their liver enzymes. And the best way to diagnose it is with a PCR of the blood, which most labs can do. And the other interesting thing, and why it's such for an ID physician, it's gratifying, is it's incredibly responds well to doxycycline. In fact, it's remarkable that within 48 hours the fevers usually abate and the patient is feeling not all completely better, but significantly better. So it's important to pick up on the lab clues and to get doxycycline. And doxycycline, I often say, is somewhat of like a diagnostic test in this illness, that if they respond quickly and you have a suspicion, then it most likely is anaplasmosis. Okay.
Let me go over one more question. I got about 40 seconds, so let's see if you can answer it that quickly. You write a patient is unlikely to have babesiosis with a normal LDH.
Yeah. So this just gets back to what I was saying about babesiosis before, where it's a hemolytic disease. It causes the red blood cells to lyse, and one of the blood markers for hemolysis is the lactate dehydrogenase, the LDH. So if the LDH is not elevated and the bilirubin, indirect bilirubin, is not elevated, then it's unlikely the patient's hemolyzing, so it's unlikely they have babesiosis.